Hi, this is Michael Altos, and we're back with the cardiovascular system part 2. We're talking about antiarrhythmics and calcium channel blockers, and this is the second video in this segment. The next drug we want to discuss is adenosine. Adenosine is actually an endogenous substance. It's a vasodilator, especially a coronary dilator, and it decreases myocardial oxygen consumption. It's a remarkably short-acting drug with a half-time of just around a second. Adenosine stimulates supraventricular potassium channels. It causes them to be hyperpolarized, which basically decreases their polarization, their depolarization. Ventricular myocytes don't have these channels, and so adenosine is really going to work only in supraventricular tissues. Adenosine has multiple uses. It can be used to identify and treat any sort of AV nodal supraventricular tachycardias, reentrant tachycardias, or atrial tachycardias. And in this case, it's given as a 6 milligram rapid IV bolus. In fact, it's recommended to give it through the largest or most central IV you have as a rapid push and followed with a saline flush. If that doesn't work, a second dose can be given at 12 milligrams IV, and that can be repeated for a third dose if necessary. Now, adenosine is not going to work for atrial fibrillation or atrial flutter because it really works at the AV node, and it's also not going to work for anything in the ventricle like ventricular tachycardia. We want to be careful in patients who have heart block or sick sinus syndrome, and probably you should have a pacemaker available before you give adenosine to these patients. And adenosine is really one of the treatments for choice in patients who have regular narrow complex supraventricular tachycardias. Just as an aside, and this is a physiology note that we don't need to get into in any detail in this lecture, but any agent that blocks the AV node, and that includes calcium channel blockers, beta blockers, and adenosine as well, none of these agents should be given in a patient who has an anterograde accessory pathway. Now, adenosine does cause transient heart block because of its action at the AV node, and you may see a pause or brief ventricular asystole. And here's a great picture of a patient who's in SVT. You can see their heart rate is well over 150. The adenosine is given. We have a couple beats, and then some slowing, and a long pause. And depending on the dose and the condition of the patient, the pause can be pretty impressive. Again, you would probably want to have an external pacemaker available before you administer adenosine to a patient. The side effects of adenosine are related to its vasodilating properties, so you may experience flushing, shortness of breath, chest pain, bronchospasm, or a metallic taste in the mouth. And adenosine does have other uses, so it can be used as an infusion for controlled hypotension. It can be given for the specific purpose of causing that ventricular pause, that asystole, in a case where the surgeon needs there to be no pulsation for a short period of time, for example, during clipping of an aneurysm or deployment of an endovascular heart valve or an aortic stent. Adenosine is also used in pharmacologic stress testing because of its vasodilating properties. Take a moment here to think about what we've discussed and jot down any questions you might have. The last class of drugs we want to discuss here are the calcium channel blockers. These drugs, as you might expect from the name, bind to calcium channels, specifically the L-type voltage-gated calcium channels. These are the channels that are found on cardiac and vascular smooth muscle. By blocking these channels, it decreases intracellular calcium, and this leads to 4 key actions. It decreases myocardial contractility, it decreases heart rate, decreases activity at the SA and AV nodes, and causes relaxation of vascular smooth muscle. Based on these effects, we expect that there are a few types of patients who may be at risk and when these drugs are given, and caution should be used. Those would be patients who already have impaired left ventricular function, since this will further decrease contractility, and patients who are hypovolemic because of the vascular smooth muscle relaxation. Calcium channel blockers are highly protein bound and they're metabolized in the liver. They can potentiate the effect of neuromuscular blocking drugs. When given IV, these drugs are commonly given as a bolus or a continuous infusion. And not surprisingly, just like they potentiate the effect of neuromuscular blocking drugs, they can also potentiate the activity of local anesthetics by inhibiting sodium ion flow, and this can actually increase risk of local anesthetic toxicity in patients who receive high doses of local anesthetics. The first calcium channel blocker we want to discuss is diltiazem, also called Cardizem. This is probably a first-line medication for supraventricular tachydysrhythmias in this family. By blocking the channels of the AV node, it prevents transmission of the supraventricular tachycardia to the ventricle and can also interrupt the reentrant pathway. Diltiazem is usually given as a 0.25 milligram per kilogram bolus, which is about 20 milligrams, and this should be a slow bolus given over about 2 minutes. If needed, a second dose can be given at a higher dose, 0.35 milligrams per kilogram, given anywhere between 2 and 15 minutes after the first dose. A diltiazem infusion can also be started anywhere between 5 and 15 milligrams per hour. There's also some role for diltiazem in control of chronic hypertension by causing vasodilation of the peripheral arteries with an elimination half-life of 4 to 6 hours. The drug is also available orally in an extended release formulation. Side effects of diltiazem include the vasodilatory effects, so dizziness and headaches and flushing. It can also cause gingival hyperplasia, and should probably be avoided in patients who have an acute MI or hypotension and second and third degree heart block. And all of these are related, if I just go back for a moment, to the 4 key effects of calcium channel blockers that we discussed earlier. And as I said before, this drug is available not only IV, but in immediate, sustained, and extended release oral forms for management of angina, hypertension, and atrial fibrillation and atrial flutter for rate control. Another drug that acts in a similar way is Verapamil. Even though it's from a different chemical family, it's also a calcium channel blocker used for the treatment of supraventricular tachydysrhythmias. And as we expect, when we cause AV node depression, there's some risk for bradycardia. Verapamil is also used in the treatment of angina and hypertension due to its vasodilating actions. And the side effects are very similar to those of diltiazem. Verapamil is also sometimes used in treatment of migraine headaches and cluster headaches, with an elimination half-time of 6 to 12 hours. So we've talked about 2 calcium channel blockers that have a primary effect on the heart. Other calcium channel blockers really have no direct effect on the heart. And these are the dihydropyridine calcium channel blockers. These include drugs like nifedipine, which is useful in the treatment of angina and also coronary vasospasm, and it causes both coronary and peripheral artery vasodilation, so we expect that they will lower blood pressure as well. Nimodipine is similar to nifedipine, except it can cross the blood-brain barrier, and so it's an excellent drug for the treatment of cerebral vasospasm, which is something that you commonly see in patients who have suffered an intracranial hemorrhage. Other calcium channel blockers that act primarily on the vasculature include nicardipine, or cardine, which really has very little, if any, effect on the heart, and works primarily just on those smooth muscles in the peripheral vasculature. So this is used for treatment of angina and hypertension by causing coronary and peripheral artery vasodilation. And nicardipine is typically started at 5 milligrams per hour IV infusion, and you can increase it by 2.5 milligrams per hour every 5 minutes, up to a total of 15 milligrams per hour. Nicardipine also has tocolytic action, which means it has the potential to stop labor. So you may see this drug used occasionally in the labor and delivery floor on patients who are having premature labor. A newer version of this drug exists called clevidipine or Cleviprex This drug exists in a lipid emulsion, and so it looks exactly like propofol. Unlike nicardipine, which is fast-acting, but as we saw here, we adjust the rate every 5 minutes, clevidipine has an elimination half-time of just 1 minute because it's metabolized by nonspecific plasma and tissue esterases. So this drug is a super fast-acting drug. Usually we start at 1 to 2 milligrams per hour and titrate up to the effect that we desire. Another drug that you might be familiar with is amlodipine, or Norvasc, which is an oral preparation similar to nifedipine and nicardipine, and it's used for management of hypertension. And you'll see many patients who take Norvasc or another drug related to it. Just to conclude, this is a little chart I made, and I encourage you to make charts like this. Whenever you're learning about a new class of drugs, sometimes it's helpful to group the drugs into similar and different categories, and then start to see what are the common and differing effects for each drug. So here we see what I would call Verapamil and diltiazem are like the cardiac calcium channel blockers. And here's nifedipine, nicardipine, clevidipine, which I think of as more like the vascular calcium channel blockers. And you can see they have some similarities in that they both tend to drop blood pressure, but these tend to drop heart rate, whereas these probably cause a little bit of a reflex tachycardia since they have no direct effect on the heart. And so you can look over this table, try to create tables of your own, and if this is helpful for you to remember how the different drugs group together and work, then that's great. That's it for this session. Please let me know if you have any questions, and we'll look forward to seeing you in the next round of videos.